Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI oncology tumor board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. A 58-year-old male with newly diagnosed rectal cancer, T3N2b, with a history of diabetes and neuropathy. So what treatment might you offer in the context of significant peripheral neuropathy? The patient initially presented with hematochezia for 1 year, but was unable to schedule a colonoscopy due to COVID-19. This is a story we've all heard very many times. The patient also had difficulty with their stooling and ultimately had several episodes of fecal incontinence. The patient does have a history of type 2 diabetes, hypertension, diabetic neuropathy with significant neuropathy to the bilateral feet, upper extremities, as well, and secondary to neck injury 7 years ago. The patient denies any smoking or alcohol or illicit drug use, is an administrative assistant, and is able to type, but some days are actually more difficult from the neuropathy. As far as the family history goes, the patient had a mother who had lung cancer in the 70s, but no other family history of cancer. As far as the treatment history, the patient again had onset of hematochezia in March 2020, just as COVID-19 pandemic was hitting. The colonoscopy was almost a year later and showed an ulcerated, partially obstructing, medium-sized, partially circumferential mass involving 2/3 of the lumen surface. An MRI of the pelvis showed a T3N2b mass 7 centimeters from the anal verge. The circumferential right resection margin was involved, and there was no sphincter involvement. A CEA level at that time was 105. And Dr. Siegel, we have the MRI of the pelvis here, if you can walk us through it.
Yeah, you can see on this one sagittal view that there's a fairly long segment tumor, predominantly involving the mid-rectum. Also, if you look posteriorly, there's, I guess, what I would call like little tendrils, or in addition to thickening of the wall, little extensions extending beyond the wall into the adjacent fat. That's not always indicative of T3 disease, but it often is.
Gotcha.
And then there's also, not as well in view here, but multiple small presacral lymph nodes.
All right. Well, we've covered rectal cancer a couple of times, and this is, as we've all agreed on, is a very multidisciplinary discussion. But why don't we walk through one more time just your preferred treatment algorithm for a rectal cancer. Again, this is a T3N2b. We'll start with Dr. Patel, if you'd like.
Yeah, for this case, a mid-rectal tumor, N2b disease, I think at our institution, we would likely start with systemic therapy with FOLFOX, and then follow with restaging and chemoradiation as a TNT approach.
Got you. And Dr. Weiser?
Yeah, I would agree with that. I think, as Dr. Patel alluded to before, I would expect a response after a cycle or two, and bowel function would improve quite dramatically with that approach.
All right, and then Dr. Weinberg, you get the tough question. This patient's got really bad neuropathy. So TNT, we usually think of FOLFOX. So what would your treatment plan change at all due to the neuropathy?
Yeah, I mean, this is almost an absolute contraindication, right? If the patient's neuropathy is that severe, I think it would have to be a really, well, first of all, we'd have a neurologist evaluate this patient and really see if there's any way to improve that, because as you know, oxaliplatin is the ideal agent in total neoadjuvant approaches. If oxaliplatin is absolutely contraindicated, as it might be very well in this patient, we would be considering either fluoropyrimidine alone or even irinotecan, which I know is controversial in the context of neoadjuvant, but if a response is essential, we'd certainly have that discussion at our multidisciplinary tumor board in this circumstance. It is a tough case. I'm curious to know what the panel would do too.
Yeah, no, I think the panel definitely concurs that it's going to have to be a multidisciplinary discussion. And you know, it's interesting because I know from my own experience, when I say multidisciplinary discussion, not only do I want the surgeons and the radiation oncologists and the radiologists and the interventional radiologists to be there, but I personally also want, if I can, sort of duplicates of each discipline. So I definitely want another medical oncologist or two giving me a second guess as to what my choices are. So these decisions are often very, very difficult. I think the panel overall did recommend a total neoadjuvant approach of chemotherapy followed by chemotherapy, radiation therapy, then surgery. But the real challenge is, is there any room to be able to use oxaliplatin, or would you consider using FOLFIRI, which is definitely sort of not the standard, but because of the neuropathy might be all you're left to be able to do.